Okay, guys, picking up where we left off with Synagis. So Synagis is not necessarily a vaccine that will prevent RSV, but we're going to talk about it. Just to recap about RSV, it usually occurs in the winter months and early spring. It is very, very contagious among household contacts. There's no vaccine for RSV currently. The best prevention for spread of RSV is hand washing, alcohol-based hand rubs, and staying away from people that are infected. If a child is hospitalized or otherwise diagnosed with RSV, they should be placed under contact precautions. We talked about that. But there is something that can be done for those children considered high risk, meaning if they catch RSV, they stand a good chance of becoming ill enough that they may need to be hospitalized. So for high risk children, there is something called immunoprophylaxis, which is our Synagis. It has been proven to decrease the rate of hospitalization in these children due to RSV bronchiolitis. So this vaccine, well, it's not really a vaccine, but this therapy, and it's fine if you want to call it a vaccine. I believe we do. We refer to it as the Synagis vaccine, but just so you're clear that it does not prevent RSV, it decreases the rate of hospitalization in high-risk children who contract RSV bronchiolitis. It is an IM injection that is given right before the start of RSV season and is continued monthly for a total of 5 doses. So if a premature baby that is considered, because of their prematurity and the season of their birth, to be in the high-risk category, we actually give the first dose of Synagis while they're still in the hospital if they were to be discharged during the season. So this medicine, like I said, has been shown to decrease the rate of hospitalization, but there has not been any significant evidence that has shown a decrease in mortality. And it has not been shown to be cost effective for use in all at-risk children. So just because you are at risk of contracting RSV does not mean that Synagis will help you at all. We're all at risk. Just because you are a child or a newborn or a toddler who may have a harder time with RSV does not necessarily mean that you qualify for the vaccine. So as far as Medicaid is concerned, they are very particular on who, and pharmaceutical companies, as far as who will be covered for this. There are certain criteria that has to be met for this medication to be paid for. And you can see here an example, premature infants less than 32 weeks, and then it should be continued until they're 6 months old or the end of RSV season. If they were preemies 32 to 36 weeks, then they suggest that they get it until they're 3 months old or the end of season. And then you can see how the recommendations go on from there. So on this slide, now I'm just going to call it Synagis because I'm not going to tackle that generic name, but do be able to recognize the generic name. This prophylaxis, is for selected infants less than 2 years old. During the season, November to March, they get it monthly for however many doses they need or they qualify for according to the recommendations. Other than that, the best prevention that we have is hand washing, avoiding passive smoke exposure, and remember what I said about breastfeeding conferring an advantage for these children, specifically with their tolerance of RSV bronchiolitis. Now this is from the DHH website, the Department of Health and Hospitals in Louisiana. I'm looking at RSV data for Louisiana over a 5-week period from October 2018 until, looks like, yeah, so it's not just over a 5-week period, from October 2018 to September 2019. And you can see as far as the season goes, from the months of October to the month of February or March, that was our season consistently, with just slight variations. So we are approaching RSV season now. And the concern for me has been in the hospital, whether or not the nurses are going to be allowed to wear gowns for these RSV babies because of the contagiousness and the amount of time that the pathogen can stay alive on inanimate objects. So for now, even if they're on contact precautions, we don't have gowns available, but I'm just wondering if that's going to change. And then here, this is an example from the DHH website again for January to February of 2017, but I like the list of viruses that it shares with us because it is very representative of what we see on a respiratory viral panel that we send off. We do the nasal swab and we're trying to identify what virus is causing their bronchiolitis or cold-like symptoms so that we know how to prevent transmission to other patients. And you can see in the large purple area here, we have rhino and enterovirus, which we have already had a few patients test positive for that. And then our light green area, which is our largest piece of the pie, we have RSV. So RSV and rhino entero are our two biggest culprits in the hospital setting that we're seeing. And after that, we had adeno and coronavirus. Now, of course, this coronavirus is not COVID. It's not the same as what we're seeing now. Coronavirus has been around for a very long time. This is a different strain. But as well, we also have parainfluenza. That you can see the 4 different strains of parainfluenza listed here that are responsible for our croup viruses. In most cases, usually it's parainfluenza 1. And then we have our human metapneumovirus. We're seeing more and more of that. So this pretty interesting data. You can get, I can spend hours on the DHH website. I enjoy that more than I do the CDC just because it is more localized. You can get information and data localized by parish, and it's very informative. I'm not going to say a whole lot about bronchitis other than the fact that it is usually from a viral infection. So when we talk about bronchitis, after we just talked about bronchiolitis, bronchiolitis is happening, let me get my little highlighter thing, or my laser pointer. Bronchiolitis is out here in the tentacles, in our bronchioles, whereas bronchitis is happening closer to our bronchus. We've got our left main stem and our right main stem bronchi, and that's where our bronchitis is happening. But the same situation as with bronchiolitis is occurring with the inflammation and the mucus production. It's usually seen in the wintertime, dry, hacky cough, worse at night, may or may not be productive, but that cough is the main symptom. It's typically caused by a rhinovirus. And whether or not antibiotics are prescribed for this depends on if the provider feels like a secondary bacterial infection has set in. So just if you didn't know that, now you know that bronchitis is typically caused by a virus, and just because you've been diagnosed with bronchitis does not mean that you need antibiotics. And here's another gooey picture showing you a cross-section of a normal bronchi compared to a bronchi that is swollen and inflamed with the mucus production like we see in bronchitis. All right, pneumonia. Children less than 5 tend to develop viral pneumonias due to things like RSV, the flu, human metapneumovirus, parainfluenza, adenovirus. So kids less than 5 tend to develop viral pneumonias. Children over 5 tend to develop bacterial pneumonias. So that is just a blanket statement. It does not mean that the opposites cannot occur. This is on average. So if we look at our picture here, we see an alveolar sacs in a healthy lung compared to a lung with pneumonia. And this is where your air exchange is occurring within the alveoli. And you can see, just like in the bronchioles and the bronchi, when this infection sets in, our alveolar walls are thickened, and as the cells are attracted to this inflammation, we have mucus production. Fluid and blood collects within these sacs, and it makes the exchange of oxygen more difficult. In this picture here, you know, I love x-rays. So we're going to look at a couple of different kinds. You're not going to be tested on x-rays, guys. I just think it's interesting, and I think that it's a good practice to look at your client's x-rays and correlate that with your assessment. You can have a patient diagnosed with pneumonia without the pneumonia being even read on an x-ray, and that is called a clinical pneumonia. If you're hearing, or the provider hears crackles, and the patient is in obvious respiratory distress and has a fever, of course they could have a viral pneumonia without radiographic evidence, and that would be labeled as a clinical pneumonia. But anyway, we're going to play around with some x-rays. Please take note on page 1050 or page 1050. There is a section, I believe it's called Take Note, and it discusses how in the United States, the prevalence of pneumonia has markedly decreased due to vaccines such as the flu vaccine, the Hib vaccine, and the measles vaccine. So here again, we have another reason to vaccinate for the measles or the flu. The evidence has shown that the rates of pneumonia, bacterial and viral, have decreased with vaccine administration. So in this picture, what should I do with, I don't know what I want to do. Maybe I want to annotate. So, nope, I don't want to do that one. I'm sorry, y'all, I have to play Spotlight. Okay. Can you see? Now, I wish I could make it diagonal, and I probably can. I just don't know how. We're looking right here. And I can do this too. Hang on. Let me see what happens when I do this. There's their heart. Oh my gosh. I'm sorry. I've got to stop. So this is even better. Yeah, I like this. Here and here. Oh yeah, that's better. Where is that? What part of our lung? Number one, this is our right lung, right? We have 3 lobes: right upper, right middle, right lower. So this pneumonia is in our right middle lobe. Air should be black. Solid things such as organs or bone, dense, because of the density, they are white on x-ray. If you look here, you see, let's see. I don't know what's happening here. Forget that one. Anyway, if you look, oh my gosh, y'all, I'm gonna get on your nerves, I'm sorry. Make it stop. There we go. Here, you see blackness. That's air. That's called an air bronchogram. When they breathe in our trachea leading down to our bronchus, that blackness is our air bronchogram. And when we had swelling in our upper airway due to croup, we had the steeple sign there. And that was visible because of the tissue swelling and the narrowing of the air bronchogram. So in this case, we have white in the shape of the right middle lobe that should not be there. It ought to be just as black as these other areas. So this is called a lobar pneumonia, L-O-B-A-R, lobar. When we have a lobar pneumonia, that tends to be bacterial. So FYI, bacterial pneumonias tend to settle in, they tend to consolidate in a particular lobe, sometimes taking up the whole lobe. So that's not always, I'm not saying always, I'm saying on average. It's a clue. A lobar pneumonia is a clue that we're dealing with something bacterial. Let me clear my drawings. So here, do you see a lobar pneumonia? I do not, but I don't see enough black. Here I can easily see my air bronchogram. You see it, the black there? I see black up here in my upper lobes, but I sure do see a lot of haziness, cloudiness here. This is an image from a patient with, I swear on the captions, I just saw the words black bear. Did I say black bear? I don't remember saying that. This is an image from a patient diagnosed with viral pneumonia. Viruses cause 80 to 85% of all pneumonias. You hear me? 80 to 85% of all pneumonias are viral. Viral pneumonias are the most common type of pneumonia in kids. We said earlier, less than 5. This resource says less than 3. And this X-ray was read as patchy infiltrates in multiple lobes. I can believe that. Patchy infiltrates in multiple lobes. So that's what a viral pneumonia, one image looks like. So up here, I'm seeing something that looks like a lobar pneumonia. And sure enough, the radiologist read this as a right lower lobe pneumonia. If I zoom in here, just so you can see it a little bit better. Here we have a right lower lobe pneumonia. And then here, that is a mess. There's not much air or black at all. This is a viral pneumonia, and this patient is pretty darn sick. They have diffuse peribronchial infiltrates with associated airspace consolidation that obscures the heart border. So if you look back up here, do you see how it's easy to identify the border of the heart? But here, those are the signs that radiologists look for. There are certain context clues that they look for when interpreting X-rays, and one is the border of the heart, and we can't see it here. They know where the heart is, or where it should be, but the borders are not visible. That is called the shaggy heart sign. And also, the radiologist noted that a patchy alveolar infiltrate is also present in the right upper lung, and that would be this part up here. So we have diffuse peribronchial infiltrates all around this area and this area, and then this right upper lobe issue. So that would be lobar. This would be our bacterial lobar pattern of consolidation. This X-ray is actually in a patient with bacterial pneumonia caused by strep pneumoniae. And that is, if you're going to have a bacterial pneumonia, then in children less than 5, we tend to see strep pneumoniae. In children older than 5, we tend to see mycoplasma. So we have already had a few patients that we have taken care of in the clinical setting that have had mycoplasma pneumoniae. So pneumonia from mycoplasma pneumoniae. And if you think back to the ages of your children, see if that correlates as far as older than 5 or less than 5. In older children, we frequently see one of their main complaints with mycoplasma pneumonia being GI symptoms, with abdominal pain, things like that. So speaking of mycoplasma pneumonia, this one represents an X-ray with mycoplasma. The one before was strep pneumoniae in a smaller child. This is mycoplasma. And really, I don't see a specific lobar pattern. Remember, mycoplasma presents like a virus, but in the end, years into it, we discovered that it responds to antibiotics. And that's why we call mycoplasma an atypical bacterium or bacterial infection. It is responds to antibiotics, but it acts like a virus. So we have a typical viral pattern here. We have an initial acute interstitial inflammatory process, and we ended up with just a diffuse, fine pattern here that just is cloudy and hazy. So sometimes it's hard to see anything at all on the x-ray other than overexpansion. And when we talk about hyperexpansion, is how you'll see it indicated by the radiologist. One of those context clues that the radiologists look at is they count the number of ribs that are visible, and they start at the top and they go 1, 2, 3, 4, 5, 6, 7, 8, 9. I'm not sure if they count that 10th one or not, but there's a certain number of ribs that are expected to be visible in a healthy child or adult, and I would be lying if I told you what that number is exactly right at the moment. But when they count the ribs, if they got counted 12 and there were only supposed to be 9, why is that? Why are more ribs visible than should be? And also remember or think about, if you had a patient with mycoplasma, symptomatically, these kids are wheezing. Mycoplasma almost always, if it causes a pneumonia, causes wheezing. When you wheeze, you air trap. You can get the air in, but because of the swollen bronchioles and alveoli, it's hard to get the air out. So some air goes into those alveolar sacs, but all the air can't get out with one exhalation. So we have a prolonged expiratory phase when we wheeze because we're trying to push that air out, and the air that does not get eliminated remains trapped in the alveolar sac. Over time, with all of that air that is trapped, it builds up, and you end up with downward pressure on your diaphragm, and your lung space, the expansion there grows because of all that trapped air. And that's evident by the number of ribs that are visible on an x-ray. So a doctor can look at a perfectly normal looking x-ray with too many ribs and have a pretty good idea that this patient is wheezing or air trapping. This patient, now, there's not one area that is pure black like it should be. I see up here that we have an ET tube. An ET tube has a beveled end, and it has this white line, just like an NG tube, so that it is radio opaque, so that I can see it on x-ray. I'll also see a central line coming from their neck down into the superior vena cava. That is an internal jugular or external jugular, I'm not sure which. So this patient is on a ventilator and has a central line, so they're pretty sick. And to tell you exactly what is going on, this is a patient that had H1N1 viral pneumonia with ARDS or ARDS. On page 1053, there is a discussion about ARDS. Please review table 45.3 for more information about that. But acute respiratory distress syndrome, some people say adult respiratory distress syndrome, whatever you want to call it, when the lungs are just so sick that it is beyond the normal. Just read that section, and as far as the care plan interventions and the considerations for all the different types of pneumonia, this chapter has really useful care plans. As far as the interventions, the nursing interventions and things to consider, all of those things make for great test questions, y'all. How would the nurse respond? How would the nurse respond? What would the nurse do? What would be the priority nursing action? Those are care plan, pieces of care plans. So use your care plans. An 18-month-old child is seen in the emergency department with respiratory distress and is admitted with a diagnosis of pneumonia. Following the initial workup, the baby is still short of breath, but is rubbing his eyes as if he is sleepy. Mom wants to lay the baby down for his nap, but the baby will not lie down. What should the nurse do? How should the nurse respond? What should the nurse suggest? Rock the baby until he's asleep and then lay him down? Let mom hold him in her arms while he sleeps? The mom should allow the baby to sleep in an upright position or sedate the baby to help him rest. So the best answer would be to allow the baby to sleep in an upright position. The second best answer would be hold him in her arms while he sleeps, but it would be even better to recognize that the baby can breathe better in an upright position. And if she would put him over her shoulder and keep him upright, then he would most likely fall asleep because he could breathe easier. So the next section is about vapotherm, and I will pick up here tomorrow night. I had to do a quick recording tonight because I didn't want to do nothing at all. So I'm going to go ahead and get this one posted and try to finish up tomorrow night. See you later.